A lumbar spinal fusion is one of the biggest decisions in spine care, but many patients are recommended a fusion who don't actually need it. I'm going to walk you through the 5 main signs I use to help patients decide when a fusion is indicated, and at the end, I will apply these 5 signs to 3 different cases I saw in my clinic. Number 1, spondylolisthesis grade. The first factor is the amount of slippage in the spine. Spondylolisthesis is a dislocation injury that is graded based on the amount of dislocation, how far one vertebra has slipped relative to the one below it. There's a standard grading system. Grade 1 is a degree of slippage 0 to 25%. Grade 2 is a slippage of 25 to 50%. Grade 3 is a slippage of 50 to 75%. And grade 4 is a slippage of 75 to 100%. Most spondylolisthesis cases are grade 1. A grade 1 slip by itself is not likely to require surgery, but whether it does or not depends much more on other factors. Grade 2 is the true gray zone. The likelihood of surgery increases substantially. It's not necessarily probable, but close. But once you reach grades 3 and 4, the chances you will need a fusion at some point becomes probable. The second sign is instability. The spondylolisthesis grade tells you how far the vertebra has already dislocated. Instability tells you how much its position shifts with bending. Instability is measured with an X-ray protocol known as the dynamic X-ray series. In this protocol, you get a series of sideways X-rays in 3 positions, with the spine in a neutral position, a rounded flex position, and an arched extend position. Normally, the vertebra should shift minimally when you bend your spine. Substantial levels of sliding indicate instability. Many surgeons use thresholds around 5 millimeters of slippage as a practical marker of abnormal joint motion, though the exact cutoffs vary. Instability increases the likelihood that a spondylolisthesis may advance to a higher grade, that symptoms may progress, and that a fusion surgery may be necessary. Even so, instability alone does not automatically mandate surgery. Number 3, spondylolisthesis type. Spondylolisthesis has 2 main types. The type you have may greatly affect the likelihood that a fusion surgery will be helpful. Isthmic spondylolisthesis is caused by a fracture to the bones at the back of the spine. This fracture destabilizes the spine joint and can cause higher grade slippages and greater instability. For this reason, an isthmic spondylolisthesis is at higher risk for needing a fusion surgery than the next type of spondylolisthesis, degenerative spondylolisthesis. This one is caused by age-related disc degeneration and facet joint injury that reduce joint stability, allowing one vertebra to gradually dislocate under normal spinal loading. Here's the good news. As degeneration progresses, discs lose height, facets hypertrophy, and ligament stiffness increases. The same process that is causing the dislocation is simultaneously also stabilizing the joint. That's why it's rare for a degenerative spondylolisthesis to progress beyond a grade 1 or to exhibit a significant extent of instability. With these stable characteristics, a degenerative spondylolisthesis is less likely to require a fusion surgery than an isthmic spondylolisthesis. Number 4, this one may be surprising. Fusion surgery ultimately depends on the body forming new bone after surgery to biologically fuse the joint. The cages, screws, and rods are not the fusion itself. They are stabilization tools designed to reduce micromotion and maintain alignment long enough for the bone growth to occur. Without successful bone formation, the unstable joint is not truly fused, even if the hardware remains perfectly in place. So if we know that framework, we can understand why anything that impairs bone metabolism and healing increases the risk of bone formation failure, also known as a non-union. Common factors include osteoporosis, smoking, uncontrolled diabetes, malnutrition, a vitamin D deficiency, chronic steroid use, and hormonal deficiencies that disrupt bone formation. If your biology cannot reliably form bone, you might not be a good candidate for a fusion, even though you meet other criteria. For example, I recently told a patient with osteoporosis and chronic low weight that a non-union was the probable outcome, even though she might otherwise appear to be a reasonable surgical candidate. Number 5, I left the best for last. Symptoms are the deciding factor for most cases of whether to proceed with a fusion. There are 3 symptom patterns that meaningfully push toward fusion. One is intractable severe pain that no longer improves with changes in position or with unloading. Number 2 is progressive neurological decline, such as worsening nerve pain, weakness, or sensory loss. And number 3 is the most urgent, red flag symptoms such as bowel, bladder, or sexual dysfunction. When one of these appear, the risk to benefit ratio may begin to tilt in favor of a fusion surgery. Variability in symptoms explains why patients with dramatic imaging can sometimes wait, while others with less impressive scans cannot. Grade and instability describe what could justify surgery, but in most cases, it is the symptoms that determine whether surgery should happen and when. Here's 3 real cases of how I helped guide a patient on the decision about whether to proceed with a fusion. Case 1 is about severe spinal canal stenosis. An executive in his 60s developed central spinal stenosis. He couldn't stand for more than 2 minutes without profound leg heaviness. Surgery was appropriate, but one surgeon recommended decompression with the fusion, while a second opinion recommended decompression alone. His MRI showed severe spinal canal stenosis and a grade 1 degenerative spondylolisthesis. His dynamic X-ray series showed a 2 millimeter small amount of movement. If we apply the 5 criteria for the case, we have a low grade of spondylolisthesis, no evidence of instability on dynamic X-ray series, a degenerative spondylolisthesis subtype, no significant metabolic risk factors, and symptoms from stenosis rather than the spondylolisthesis. Here's what I advised. No fusion was necessary. His problem was neurogenic claudication from the severe spinal canal stenosis, not instability. In the absence of pathological motion at the joint, decompression alone could probably successfully address his symptoms. And sure enough, after a decompression-only procedure, his walking tolerance improved significantly, he did not develop instability, and his quality of life returned. In this case, avoiding fusion was the right call. You may be wondering, but why did that one surgeon recommend a fusion? Here's the underappreciated point. In many cases of degenerative disease, a fusion is often proposed with a decompression, not because the spine is unstable to start with, but because the surgeon worries that the decompression surgery might make the joint unstable. Because the decompression means removing bone and thickened tissue around the nerve, there's a risk that destabilizing structures can create joint instability. And that's when a fusion gets added as a safeguard. In that scenario, fusion isn't treating the original disease, it's treating a possible surgical side effect. And if there's no high-grade spondylolisthesis, no abnormal motion on flexion extension imaging, and no objective instability on clinical exam, adding a fusion is often just treating uncertainty. So unless there are exceptional factors, a fusion is too irreversible and too high risk to simply add on in the interest of theoretical risk. Case number 2, isthmic spondylolisthesis with back pain and sciatica. A yoga teacher I worked with had a grade 2 isthmic spondylolisthesis with about 5 millimeters of translation on dynamic X-rays. She had clinical evidence of bone pain, instability, and sciatica. This pain was often absent, but was provoked by spine bending. If we apply the 5 criteria for the case, we have a grade 2 spondylolisthesis, evidence of significant instability, an isthmic spondylolisthesis subtype, no significant metabolic risk factors, and symptoms from spondylolisthesis that were modifiable from activity modification. For this patient, there were a daunting number of objective risk factors for fusion surgery. But what led me to advise that she hold off was this key fact. Her broad range of symptoms were modifiable with activity. Stopping yoga completely wasn't an option for her, but we reduced her teaching load and eliminated specific movements that were provoking symptoms. With those changes, her pain wound down to minimal levels. She's still teaching yoga, her injury hasn't progressed to a higher grade, and most importantly, she hasn't required a fusion. The point, not all instability is progressive. Most instability is load dependent and modifiable. And in these cases, fusion can wait and even be completely avoided with quality physical medicine and rehabilitation. Case number 3, isthmic spondylolisthesis with progressive neurological decline. I evaluated a motivational speaker who had been a competitive butterfly swimmer in his youth. His imaging showed 2 isthmic spondylolisthesis injuries at the L4, L5, and L5S1 levels. Both were grade 1 injuries. He developed intractable sciatic pain in all positions except lying down. If we apply the 5 criteria for the case, we have grade 1 spondylolisthesis at 2 consecutive levels, evidence of significant instability, isthmic spondylolisthesis subtype, no significant metabolic risk factors, and symptoms of intractable pain and progressive neurological decline. With this patient rapidly declining and already functionally disabled, I recommended that he proceed with a spinal fusion. Unfortunately, after the surgery, he developed severe post-operative complications with even worse nerve pain. This case illustrates a difficult reality. Correct indication does not guarantee a good outcome from a fusion. It only gives the chance for success, but the risks remain. If you are considering a fusion, you and your medical team need to have clarity about at least these 3 factors. 1, can your fusion be avoided with non-operative care? 2, when does the benefit to risk ratio favor a timely fusion surgery? 3, what preoperative and postoperative plan will give you the best chances for recovery should you need a fusion? If you're dealing with conflicting recommendations, you can learn more about consulting with me here. I'm Dr. Jim, helping you decode the spine